Hi everyone, I'm Dr. Roman and I'm a blood and cancer doctor, and we are going to talk about polycythemia, also known as erythrocytosis, or simply as an elevated hemoglobin level. Now, there are different causes for polycythemia, and we are going to discuss primary polycythemia, also known as polycythemia vera, also secondary causes of polycythemia, and towards the end, we're going to talk about polycythemia induced from testosterone use, which is quite common in men who are using hormone replacement therapy or testosterone injections or gel, etc. So very exciting topic, an important topic, and let's dive in. So I'm just going to ask for one little favor. If you find this educational, please consider subscribing, like, and please leave a comment. I really enjoy reading comments, and give me some input. Make me feel that you are deriving some sort of a benefit from this. So with that being said, let's get started here. So the first thing I'm going to urge you to do is read my medical disclaimer. Just know that I am not your physician. This is for educational purposes only. I am not giving you any medical advice. So there are many causes for polycythemia. You might feel a little overwhelmed at some point, but I guarantee you that towards the end, everything will make sense. We're going to tie everything in, so do not get discouraged. Believe me, this is a lot of information. This presentation, which is dedicated more towards patients, is actually good enough for primary doctors as well, because this is what you really need to know. So just know that polycythemia or erythrocytosis, which is, as already mentioned, an elevated hemoglobin or hematocrit level. And there's two main causes, primary and secondary. That's how we divide it. And by definition, it's when your hemoglobin is greater than 16.5 in men or greater than 16 in women. There are some rare hereditary causes of erythrocytosis or polycythemia. I'm not going to get into that because this is something you're born with. You have a strong family history of this, and you've had polycythemia since you were a child. So that's not the reason for this presentation. This is the person whom had a normal hemoglobin, and for whatever reason, later on in life, their hemoglobin started to go up. And that's what we are going to concentrate on. So the first question you have to ask yourself is, do you have symptoms of polycythemia? When your hemoglobin levels are high, this can cause somewhat of a hyperviscosity syndrome inside your blood. Your blood is thicker, if you will. So you can develop pruritus, which is itchiness. In polycythemia vera, patients somewhat describe, or at times describe, itchiness, especially after taking hot showers. You're also at risk for developing blood clots, which can be both in the arterial side and the venous side. Symptoms of hyperviscosity, like for example, visual disturbances, double vision, blurry vision, headaches is quite common. There's also another entity called erythromelalgia, where your extremities, you can get, the numbness, the tingling, discoloration, painful hands. These are all symptoms which can commonly happen, mainly in polycythemia vera, but whenever your blood is very thick, you can develop these symptoms. You can also develop fatigue. If your hyperviscosity is very high, you can even develop somnolence, and you can just feel really, really down. You feel very worn out. A lot of these are very subjective, but just know that you should really monitor for these findings. You can also feel early satiety. Sometimes in polycythemia, you can have a big spleen, so when you eat, you just have early satiety. You get full very fast because that spleen is occupying space in your abdomen. Now, the normal physiology, the way that your body makes red blood cells, you have to keep in mind, you just think about your kidneys produce erythropoietin. And erythropoietin will cause or stimulate your bone marrow to make blood. And when your hemoglobin level is high enough or it's normal, then your kidneys will decrease the production of erythropoietin. And that's the way it works. Your hemoglobin is too high, erythropoietin level starts to come down. If you're anemic, then your body makes more erythropoietins to stimulate the production of red blood cells. That's the normal physiology of hemoglobin production. So The first thing when a person first presents with an elevated hemoglobin level, the first thing or the obvious thing you have to exclude is what they call a relative polycythemia. So if you think about it, your red blood cells are circulating within your veins and your arteries, and there's also liquid in between them, fluid, serum, plasma, whatever name you want to give it. Now, if your plasma volume, the amount of fluid, decreases, it contracts, then your red blood cells are going to be closer together. They're going to be more contracted, and this will cause an elevation in your hemoglobin level. But this is not normal. This tends to happen, for example, when you're severely dehydrated, when you've been given a lot of diuretics, which is kind of hard for it to happen with diuretic use, but it has been described. If you're vomiting, if you have severe diarrhea leading to dehydration, and that can definitely cause a relative polycythemia. Just know that this is self-limited. As soon as you're rehydrated, your hemoglobin level will come back down. So it's important to make sure that you do not perform a CBC or label somebody as polycythemic if they are severely dehydrated. Always rehydrate the person and then check a new CBC. So the other causes are primary polycythemia, known as polycythemia vera. We're going to go into that now. Or secondary causes of polycythemia, in which there are multiple. And again, we're going to get into much more detail. So let's start off with secondary polycythemia. And as the name says, it's a polycythemia or an elevated hemoglobin level due to a secondary cause. For example, if you're hypoxic, in other words, the oxygen level in your blood is low for whatever reason, this will stimulate the production of more red blood cells. For example, if you're a person with COPD, like chronic bronchitis, emphysema, if you're a person that at night you hypoventilate because you have obstructive sleep apnea, you're a heavy snorer at night, typically seen in heavy-set people or people with thick necks, definitely this will cause hypoxia and will lead to secondary polycythemia. People who have heart disease, mainly like a shunt inside the heart where blood is mixing from the right side of your heart to your left side of your heart, this can definitely cause hypoxia, and this can lead to secondary polycythemia. Living in high altitudes can also lead to secondary polycythemia. Renal disease, for example, people who have had a renal transplant, they are also prone to develop a secondary polycythemia, as well as renal artery stenosis. So the blood vessel feeding your kidneys is very stenotic, it's narrow, and that will cause your kidneys to produce more erythropoietin because it feels that the body is in an anemic state, and this will lead to secondary polycythemia. Tumors can do this. For example, tumors of the liver, what we call hepatoma or renal cell carcinoma, a tumor in the kidneys, can actually produce erythropoietin, causing secondary polycythemia. And last but not least, several medications. Diuretics, although rare, can do it, but the more common one are steroids, mainly anabolic steroids like bodybuilding steroids, and as we've mentioned, testosterone treatment. So this is typically for the bodybuilders or men when they have low testosterone levels and they're injecting themselves or giving themselves the testosterone patches. We also tend to see elevations in their hemoglobin levels. So these are all causes of secondary polycythemia because it's a polycythemia secondary to one of these. So quite simple. Polycythemia vera, on the other hand, is an actual disease. And this is a clonal disorder because your body has acquired or developed a mutation in a gene. The most common gene is one that we call a JAK2, and it's usually due to a JAK2 mutation, which we're going to discuss. So in other words, your body developed a mutation, and this is causing your body to make too many red blood cells, causing your polycythemia. And this can be associated with symptoms, as we already mentioned before. The itchiness or pruritus with the hot showers, the symptoms of your hand, the erythromelalgias, the headaches, the blurry issue, the blurry vision. So a lot of symptoms can occur with polycythemia vera. Just know that about a third of patients can have a big spleen. So the spleen is in the left upper quadrant of your abdomen, and this can push up against your stomach, and you can have early satiety is another finding. Now, the main risks with polycythemia vera are blood clots, and blood clots are actually the number one preventable cause of death or morbidity in patients with polycythemia vera. Also, believe it or not, bleeding. So yes, you can clot and bleed at the same time, but the bleeding is usually not a big deal. This is usually when your platelet count is very high, and we're going to go over that in a few slides, but bleeding can happen. You also have a risk for developing an acute leukemia or another entity that's called a myelofibrosis. And what happens here is because of this polycythemia vera, your bone marrow is constantly working overtime, and it starts to tire out. You start to develop scar tissue from this constant revving up of your bone marrow, and this scar tissue is fibrosis. And it's going to come to a point where your bone marrow is so fibrotic, it's so scarred, that what tends to happen is now your hemoglobin level starts to come down. And patients are happy. They're saying, you know what, my hemoglobin level is not that high anymore. And you know, it's an issue because a lot of times in due time, with continued fibrosis or scarring, you can develop anemia. And unfortunately, that's the more advanced stages of polycythemia vera. Now, how do you diagnose a polycythemia vera? Well, of course, your hemoglobin level is going to be high. A lot of times, your white blood cells and your platelets will also be high. Not always, but oftentimes they are. You're going to check. Remember, I said it's a clonal disorder due to a mutation. Well, over 90% of the times, it's due to a JAK2 V617F mutation or a JAK2 exon 12. Don't panic. It's quite simple. It's a blood test, just a simple blood test. We send it off for JAK2 V617F and JAK2 exon 12 mutation, and it's going to come back positive or negative. Positive meaning you have it, negative meaning you do not. And if it's negative, chances are you do not have polycythemia vera, although on rare occasions you can still have it. The other thing is you want to measure an erythropoietin level. Remember erythropoietin, which is made in the kidneys? Well, in polycythemia vera, since it's clonal due to a genetic disorder, the erythropoietin is not driving your red blood cell production. So erythropoietin will usually be low. So remember, in the secondary causes, your erythropoietin will be normal and quite often high. So P vera, JAK2 positive usually, and the erythropoietin level low, and quite often your white blood cells and your platelets will be elevated. So this is just a little picture kind of demonstrating everything we've already spoken about. So over here you have the bone. In the middle you have the bone marrow. Remember, your bone marrow is what makes your white blood cells, your platelets, and your red cells. So this bone marrow, because of the JAK2 mutation, is on overtime. It's working a lot harder, and it tends to bring up your white cells, your platelets, and obviously your red cells. Remember, erythropoietin level will be low, and here you have normal red blood cells, the way they circulate within the blood vessel. And as you can see here, you have a lot more red blood cells circulating, so this tends to make your blood thicker or more viscous. And then that will lead to the symptoms, which you see on this side. Here you have that rash, especially when you take hot showers, leading to the itchiness, the erythromelalgia of your hands, the tenderness. See, here is normal, here is abnormal, where you can also develop a rash, discoloration, paresthesias, which is the numbness or tingling feeling. You can also develop the bleeding, which we spoke about before. And on this side, you can see the spleen, which is located in the left upper quadrant of your abdomen, which is elevated in about a quarter, maybe a little bit more. I actually see it about half the times in patients, but just know that your spleen can be enlarged. So sometimes we'll perform a bone marrow biopsy, and the reason, remember, your bone marrow is what makes your blood, so sometimes we want to biopsy your bone marrow. And here we will look for that revved up bone marrow, the bone marrow that tends to be working overtime. We also want to look for possible fibrosis, because remember, we already spoke of the risk of myelofibrosis, which is just a fibrotic or a bone marrow full of scar tissue. And we can quantify this. We can tell you if you have a little bit of scar tissue or a lot of scar tissue. And obviously, the more fibrosis or scar tissue you have, the worse that's going to be. We can also look for blasts. Blasts are the most immature white cells in your bone marrow. If they are greater than 20%, then by definition you have an acute leukemia. Also, we can look for MDS, that's called a myelodysplastic syndrome. Don't panic. All that means is that it's a bone marrow that is not functioning the way that it should. It's a bone marrow that looks ill. You can at times see a myelodysplastic syndrome inside a bone marrow of a patient with polycythemia vera. Now, the main causes of death, as we already spoke about, clots, myelofibrosis, and AML. Just know that clots is the main one that we can prevent. The myelofibrosis tends to happen with time. This is when a person has had a P. vera for a very long time. And acute leukemia, I can tell you it's not common. I rarely see this happen, but it definitely can happen. And if you develop an acute leukemia from long-standing polycythemia vera, it tends to be quite difficult to treat. Now, the treatment. So you've been diagnosed with polycythemia vera. Remember, your JAK2 is probably positive. Your erythropoietin level is low. What are we going to do about it? Well, the first thing is we need to decide, are you low risk or are you high risk? And obviously, the risk is more leaning towards what is your risk of forming blood clots. And we will look if you are, well, the definition of low risk. So low risk means you are less than 60 years of age and you have never had a blood clot. So, and the high risk is if you're older than 60 or you have had a blood clot. The reason is the older you are, the higher your risk of forming blood clots. So that's what makes you high risk versus low risk. And obviously, if you're younger but you've had a blood clot, that already places you at high risk, because if you've had one clot, you're at higher risk for developing another one. So what are the treatment options? Well, first of all, it's phlebotomy. That's drawing blood, donating blood, if you will. You go to the blood center, they take out a unit of blood. The goal here is to try to keep your hematocrit. When you get your blood test, you'll see hemoglobin, and right below it, you will have your hematocrit. And the goal is to keep your hematocrit less than 45%. That's the ultimate goal. Another option is giving aspirin, because remember, your aspirin will make your blood thinner, if you will. It will reduce the risks of forming blood clots. And last but not least is cytoreductive therapy. Now, these are medications that we give that can reduce the amount of blood your bone marrow is making. Okay, so these are for P. vera, these are the options. So the treatment really depends, are you low risk or high risk? In general, if you're low risk, meaning you're less than 60 and you've never had a blood clot, we tend to give you aspirin and we take blood out from time to time. How often? It all depends. Our goal is to keep your hemoglobin less than 40, your hematocrit less than 45, your hematocrit less than 45. So you may require, from experience, I've had patients that require a phlebotomy every 2 months, some every 4 months. I have patients that require a blood donation or a phlebotomy every 6 months. It all depends. You got to find what keeps your hematocrit less than 45. And obviously the aspirin. Now, if you're high risk, meaning you've had a blood clot and you're greater than 60, then we tend to do phlebotomy. We also give you aspirin, but in these cases, we will add cytoreductive therapy. In other words, we're going to give you a medication to help reduce the production of blood. Now, what options do we have? Well, we have several. The first one, the one that I used most frequently, is hydroxyurea or Hydrea. It's a very good medication. The usual starting dose is about 500 milligrams once to twice a day. And the whole goal here is to try to keep your hematocrit less than 45. I try to balance it out between phlebotomy and medication, because I don't want to give you too much medication that may cause harm. But at the same time, I don't want you requiring a phlebotomy every month. So, it's a little balance. Other options are interferon alpha. Also, if these medications are not working well or you're not tolerating them well, then you have ruxolitinib is an option, busulfan, which we rarely use. And here's another option which I've never used but is out there, and it's an injectable medication, rusfertide. If the patient has had a venous blood clot, for example, they've had what they call a DVT or a pulmonary embolism, DVT for deep vein thrombosis, then in these cases, we will use anticoagulation. Remember, aspirin is an antiplatelet. In these cases, we need anticoagulation, for example, like warfarin or some of the other anticoagulants out there that are all very good. Something you need to discuss with your physician. But remember, if you've had a DVT or a pulmonary embolism, aspirin is not good enough. You need anticoagulation. The goals of therapy, as we've already mentioned, number one, keep that hematocrit less than 45 or as close to it as possible. Preventing blood clots. Remember, it's the number one cause of death in P. vera, and it's the number one preventable cause of death. So we need to take action, give the aspirin. Prevent cytopenias. What I mean by this is if you're giving the hydroxyurea or the medications, the cytoreductive therapy, this can also decrease your platelets and your white blood cells. And if that happens, that can lead to other issues. So you want to monitor the blood and make sure that your white blood cells and your platelets do not go low or not very low. So keep that in mind. The other thing, I'm giving you a lot of information here, so don't get discouraged, but just know if your platelet count is greater than 1 million, you may bleed. Now, this is something that people have a hard time with because platelets, for the most part, you're afraid of clotting because platelets, when they stick together, that's a blood clot. But just know that in patients with P. vera and your platelet count is greater than 1 million, I've typically seen it when the platelet count is greater than 1.5 million. But you can develop something that's called an acquired von Willebrand's disease. And if once your platelet count goes below 1 million, the acquired von Willebrand's disease tends to disappear. There is a test out there, it's called the aristocetin cofactor assay, and it's usually less than 30 if you really want to test for this. But for the most part, we start you on cytoreductive therapy. We try to get your platelet count below 1 million, and at that point, I usually start you on the aspirin. You can give aspirin just, especially if they're greater than 1 million. Be careful with the whole bleeding issue. I just make sure the patient's not bleeding. I warn them because on one hand, they do have a clotting risk, but on the other hand, they do have a bleeding risk from this entity, the acquired von Willebrand's disease. So you can either reduce the platelet count less than 1 million and then start them on aspirin, or give them the cytoreductive therapy, give them the aspirin, and just warn them, listen, if you start bleeding in the skin, a nosebleed, just stop the aspirin until your platelet count is less than 1 million. You guys really, I don't think you need to know this, but just thought I'd throw that in there. And of course, control hypertension, diabetes, and hyperlipidemia. Think about it. P. vera tends to happen in older people. Your risk are blood clots, high blood pressure, diabetes, and hypercholesterolemia or increased lipids all can increase your clotting risk. So you want to control these as much as possible. This is just common sense. Just thought I'd throw this in there. If you're pregnant or you're planning on becoming pregnant, do not use Hydrea. In these cases, we use interferon alpha. And overall, the prognosis. So how do people with P. vera do? And for the most part, they do pretty well. If you control their hematocrit level, you keep it below 45 or as close to it as possible. You give them the aspirin. If they're high risk, you give them cytoreductive therapy. Usually, the prognosis is measured in years or decades because for the most part, patients tend to do pretty well. My patients overall, they've done very well. And actually, the few people or the few patients that have not done so well were not compliant. They were not taking their medications. They would not go for their phlebotomies. They were not taking their aspirin. So what does that tell you? Make sure you follow your doctor's advice. All right, now secondary polycythemia, just know that the JAK2 is going to be negative. Remember, this is secondary to another cause, the heart disease, the lung disease, the obstructive sleep apnea, etc. Just know that your JAK2 is negative, and there's also another blood test which you want to make sure is always negative in all these entities, and that's called the BCR-ABL. This is a blood test that's found in chronic myeloid leukemia. Not pertinent to this, but I always make sure that the BCR-ABL is negative. And remember, it's secondary polycythemia, so your erythropoietin level will be normal or high. Because if it's low, you're thinking P. vera. okay? So I'm being repetitive so you learn. The first treatment for secondary polycythemia, obviously, is treat the underlying disorder. What is causing the polycythemia? Is it lung disease? So if you have COPD, for example, be aggressive with COPD treatment. Quit smoking. If it's due to the heart, treat the heart. If it's due to obstructive sleep apnea, use your CPAP machine at night. You may need a sleep study diagnosed with obstructive sleep apnea, and you may need the CPAP machine that you sleep with at night. That'll bring down your hemoglobin level. So whatever the cause, if you have a kidney tumor or a liver tumor, have the tumor addressed, removed. So again, the whole idea is find the cause and address it, improve it, remove it, whatever the case may be. Consider aspirin. You don't have to, but consider it, especially if the patient has other risk factors like diabetes, high blood pressure, hyperlipidemia, etc. If they're older age, their risk of clots goes up, so consider giving them aspirin. Phlebotomy, this is controversial. So if a person's hemoglobin is very high and they're developing some symptoms, for example, they're telling you they constantly have headaches, visual issues, could you do a phlebotomy? The answer is yes. The problem is, are those symptoms due to the high hemoglobin or are they due to other issues? And that's where the art of medicine comes into play. But just know you got to be careful, because remember, if this person has heart disease or lung disease and their hemoglobin is high, their body wants it that high. And if you decrease that hemoglobin or the hematocrit level too much, you can actually cause worse symptoms. You may decompensate them. So you have to be careful. And the rule of thumb is, if you're going to do a phlebotomy, try to keep the hematocrit greater than 55%. Remember, for P. vera, the goal is hematocrit less than 45. For secondary polycythemia, you don't want it less than 55. Because you can decompensate the patient. Very important to remember that. And of course, it's not P. vera, so you're not going to give medications like hydroxyurea. You're not going to give cytoreductive therapy. Polycythemia and testosterone. So everybody wake up. Very important. I see this quite often. And a lot of times we don't know what to do with polycythemia induced from testosterone replacement. Guys, this is us. Especially in the older patient population or bodybuilders, we tend to see hemoglobin levels go up when they're injecting testosterone or receiving testosterone. For the most part, we tend to check a CBC at 3 months, at 6 months, and at 12 months after the start of testosterone. Just know that within 1 month of your testosterone dose, your body tends to start producing hemoglobin. And it's also dose dependent, meaning the higher the testosterone dose or the more testosterone you get, the higher the chances your hemoglobin will go up. Now, what do we do about this? Good evidence-based guidelines are lacking. Everything is based on expert consensus. So really, there is no good data, no good clinical trial that will tell us how to manage this. So you always got to keep that in mind. So it's really dependent upon you and your physician. But overall, most experts recommend considering holding the testosterone replacement if your hematocrit is greater than 54%. So around 54, 55%, consider stopping the testosterone or at a minimum decreasing the dose of the testosterone, because remember, it is dose dependent. Just know that the different formulations of testosterone, it can be either an injectable, so an intramuscular injection, a patch, the roll-on, which a lot of patients put under their armpits, for example. Just know that the injectable is the one that tends to elevate hemoglobin levels the most. So maybe if you have a person on an intramuscular shot of testosterone, you can consider a patch or one of the other formulations. So I thought I'd let you know that as well. So the goal is to try to keep the hematocrit less than 54%. And of course, you're going to ask about symptoms. Is this patient having the headaches, the blurry vision, the rash when they take a hot shower, whatever the case may be? You just want to make sure that they are asymptomatic. So as I already mentioned, you can consider phlebotomy, consider reducing the dose of testosterone, or stopping it or using another formulation, and obviously exclude other causes. What I tend to see, older guys injecting testosterone and their hemoglobin level comes up, a lot of times I'll find another cause. For example, they're getting testosterone and they're smoking, which is a recipe for disaster because that can increase your clotting risk. Or they may have obstructive sleep apnea, or they may have lung disease. So if you address that secondary cause, like for example, the obstructive sleep apnea with the CPAP machine, or you improve their lung function with bronchodilators, etc., or they quit smoking, even if they continue their testosterone, a lot of times I will notice that their hemoglobin level or their hematocrit will go down. So something to consider. I've actually had a few patients where treating that cause will reduce their hemoglobin level, and I did not have to touch their testosterone dose. All right, so that's it. You made it. I hope you found this informative. I know it's a lot of information. It's a lot to take in, but guys, you need to know this. If you have polycythemia, you need to know this so you can have that good conversation with your doctor and know what's going on. Okay, you don't want to be at the mercy of your physician. You want to engage. You want to know what questions to ask. So remember, like, subscribe, leave a comment, and I'll catch you on the next video.